When we talk about Selinexor, I think the most important thing to recognize is who these patients were that were studied in STORM 2 that led to the FDA approval. These are patients who are triple-class refractory, meaning proteasome inhibitors, IMiDs, and CD38. Not only were they triple-class refractory, over 95% of patients were refractory to the most potent drug in each class, which means carfilzomib, pomalidomide, and daratumumab. So historically, there is no FDA-approved therapy for this class. And these patients were also the eligibility criteria were very permissive. So neutrophil count of 1,000, platelets could be 75, but even as low as 50,000. Creatinine clearance was very permissive at over 30. So I think when you have a very sick population with very permissive eligibility criteria, it sets the stage of what we expect to see. And the response rate was about 26%, PFS 3.5 months. Now, while those numbers might seem modest, it's important to remember that every drug that's been approved in myeloma, which includes pomalidomide, carfilzomib, dara in recent years with single-agent activity, all had similar profiles of a response rate of mid-20s, PFS of 3 to 3.5 months. What's different now is it's getting harder and harder to hit those benchmarks when you've exhausted all the prior drugs. So I think the fact that we saw this response is really great for patients. And finally, I would say there was obviously toxicity, GI, heme, fatigue, sodium, those are the big ones. But generally, in our center, it was quite manageable. We've been very aggressive with supportive care. In fact, our efficacy results are better than the overall population, and we're working on a manuscript where our response rate was over 50%, our PFS was over 5 months. And I think it speaks to the importance of supportive care for this population.